Pathology. Number of strictures. While Thompson, in examining 270 pathological specimens, found only 44 cases of multiple stricture, Guillain lays down the clinical rule that gonorrheal strictures are multiple, while traumatic strictures are single. These statements, properly interpreted, conform perfectly with each other and with the facts. Concerning traumatic strictures, there is no doubt. They are almost always single. But gonorrheal strictures, while frequently single from the pathologist point of view, often present a number of ridges to the examining sound. Clinically, therefore, gonorrheal strictures are often multiple. Pathologically, they are usually single. Seat of stricture. Thompson divides the urethra into 3 regions. 1, the bulbomembranous, including 1 inch in front of and 3/4 of an inch behind the junction of the spongy with the membranous urethra. 2, from the anterior limit of region 1 to within 2.5 inches of the meatus, embracing from 2.5 to 3 inches of the spongy urethra. 3, the first 2.5 inches of the canal from the meatus. His 270 preparations showed 320 strictures, 67% in region 1, 16% in region 2, 17% in region 3. Otis placed a majority of all strictures within the first 1 1/4 inches from the meatus, the next most common position being somewhere in the middle portion of the pendulous urethra. He believed deep urethral stricture to be far less common, but these views depended upon his theory that the urethra is a tube evenly calibrated throughout. Therefore, the points of physiological narrowing or of non-contracting infiltration left by urethritis, page 161, he denominated stricture. It is convenient to associate the region in which the stricture occurs with its cause. Thus, strictures at or near the meatus, if not congenital, are usually caused by chancrous or chancroidal ulceration, less frequently by caustic injections and by gonorrhea. Strictures of the pendulous urethra are commonly gonorrheal. Strictures of the bulb and at the bulbomembranous urethra are also commonly gonorrheal. Strictures of the membranous urethra are rarely gonorrheal, almost always traumatic. Stricture in the prostatic urethra may be gonorrheal or traumatic. Figure 47, stricture of anterior urethra. Form of stricture. In the first place, the stricture is usually chiefly built up from the floor of the canal. This is most notable in the bulb and commonly results in an eccentric position of the orifice of the stricture, close to the upper wall of the canal. The cause is not far to seek. It is in the loose floor of the canal, especially in the pocket of the bulb, that the gonococci commit their greatest ravages. It is the floor of the canal that is most often torn or crushed. It is the floor of the canal that is damaged by overdistension when urination is obstructed. In the second place, it is a matter of clinical experience that in the broad, irregular strictures that are clinically multiple, the constrictions become progressively narrower as they approach the bladder. Beginning, perhaps, at the penoscrotal angle, there is a constriction which admits a 20 French sound. A short distance farther on this, too, is obstructed, and only a 15 French will pass. And finally, the stricture in the bulb admits only a filiform instrument. In other words, the deeper extremity of the stricture, which receives the strongest impact of urine, is more irritated than the rest and contracts more rapidly. Gross pathological changes, figures 47, 48, and 49. When the strictured urethra is slit longitudinally, the mucous membrane may be found only slightly thickened and congested, or it may be cicatricial in character or covered with granulations. A band or a mass of cicatrix may replace the mucous membrane throughout its thickness and may even penetrate the corpus spongiosum. This tissue may be slight in extent, cicatricial in character, tightly contracted, or it may be exuberant, knobbed, and excessive in amount, so as to be readily felt from the outside of the canal. In this callous fibrous mass, there may be irregular areas of inflammation and suppuration. Behind the stricture, the canal is distended and more or less extensively ulcerated. And immediately in front of the stricture, there may be lesser dilatations and ulcerations. If the retention has been prolonged and grave, the upper urinary organs show the results of retention and infection, illustrated in Figure 49 and described on page 334. Microscopic changes, these have been described, page 160. Figure 48, stricture of membranous urethra. A, bladder. B, bladder neck ecchymotic. C, dilated prostatic urethra. D, verumontanum. E, one of the prostatic ducts. F, G, K, the stricture. F, dilatations in front of the tightest part of the stricture. H, orifice of small abscess cavity. K, mucous membrane in front of the stricture, thin and ulcerated. L, corpus spongiosum. M, anterior urethra. Figure 49, results of stricture. A prime, kidneys dilated, sclerosed, pyonephrotic. B prime, ureters irregularly dilated. C, bladder contracted and thickened, concentric hypertrophy. D, dilated ureteral orifice. E, prostatic urethra dilated, prostatic abscess. F to H, the stricture. F, its tightest point. G, corpora cavernosa, involved in the scar.